Welcome everyone to this presentation sponsored by Doctors Data Laboratory. In 1972, about 50 years ago, Doctors Data was the first laboratory to offer analysis of exposure to toxic metals via hair analysis. About 10 years later, Doctors Data added urine toxic metals to its environmental medicine offerings, and things grew from there. Now, I've focused on toxic metals for about the past 26 years. And today I will briefly focus on the importance of assessing toxic metals in urine as a component of the total toxic load for some of your patients. So what I'll do is I'll first provide a very brief background as to why we might even consider toxic metals. Then compare and contrast assessment of toxic metals in urine versus other biological matrices that we have mastered. Then address important details regarding sample collection instructions and our test reports. And finally, present some mini case studies to help put things in clinical perspective. Now, one of my favorite quotes ever, probably my favorite quote of all time from the CDC, was their comment years ago that the epidemics of cardiovascular, immunological, and neurological diseases are likely associated with environmental toxicants. That's huge. That's huge coming from the CDC. Now, there's some other very important considerations we have to make. They also have acknowledged, the CDC that is, about individual variability. That is, again, from the CDC, individuals vary considerably in their sensitivity to toxicants, and susceptibility to toxic effects varies with age, gender, pregnancy and nutritional status, and genetics. And when we talk about genetics, really we're talking about the phenotypic expression of associated with important single nucleotide polymorphisms. For example, the PON1, the paraoxynase 1, the glutathione S transferase. And for today's discussion, the metal ion transporters, particularly the ZIP8, which shares transport for zinc, manganese, iron, and cadmium. Now, some other important considerations that have really come to the forefront over the years, kind of in the back of our minds all along, some really important considerations. One, minimal risk levels for exposures have not considered in the past that humans bioaccumulate metals. Well, of course we do. Sponges do, worms do, we all bioaccumulate metals. Secondly, knowledge of adverse effects of toxicants are based on independent studies of a single toxicant. And that's just not the real world. Our environment is such that we are not just exposed to one particular class even of toxicants. Thirdly, metals can elicit independent, additive, or even synergistic toxic effects. So it's really important to look at the full spectrum of toxic metals that your patient is exposed to, because especially with respect to the self-hydroreactive metals, 1 + 1 does not always equal 2. And then finally, low-level exposures may be associated with long-term effects not previously recognized. That's from the National Institute of Environmental Health Sciences. So low-level exposures. Why low-level exposures? Well, let's take a look. Let's take a look at what came out of the NHANES 3 study. The huge NHANES 3 study, over 10,000 people in the US. It was concluded from that data that lead and cadmium-induced oxidative stress, should be considered among people with low exposures. So we're not just talking about major occupational exposures, okay? Low-level exposures combined with other toxicants. So why are we talking about oxidative stress with low-level exposures? Well, we know that the classic heavy metals, as they're often referred to, cadmium, lead, mercury, hexavalent chromium, but also the transition metals, iron, copper, cobalt, and nickel all promote the production of reactive nitrogen and reactive oxygen species, both radical and non-radical. Those reactive oxygen, reactive nitrogen species can indirectly affect tissues and health by depleting glutathione. Also, there can be a direct effect on specific tissues. For example, we can see oxidative damage being associated with endothelial and immune dysfunction, neuroinflammation, oxidation of lipids, proteins, and DNA. And my favorite biomarker for deep tissue oxidative stress is the urinary level of 8-hydroxy-D-guanosine. Very, very deep marker of oxidative stress. So oxidative stress is one thing, but metals can also compound exposures to other toxicants by affecting phase 1 and phase 2 detoxification. So we're all familiar with the fact that a typically more polar xenobiotic chemical entity is acted upon by cytochrome P450s, and that makes more polar that initial toxicant. Well, the problem is mercury, lead, cadmium, other metals, and our friend glyphosate can impair phase 1 detoxification. Okay, so here we have an effect of metals on just normal phase 1 detoxification. But we also have an issue at phase 2, and that is where we have that more toxic activated xenobiotic being conjugated by things like glutathione under the influence of glutathione S transferases to form these conjugates that are excreted in the urine and the bile. But once again, we have the metals. It can inhibit the glutathione S transferases, and that results in a backup of the activated xenobiotics, which are in fact pro-oxidative electrophiles, which further contribute to oxidative stress. So let's switch a little bit now and talk about actual routes of excretion of toxic elements. The primary routes of excretion of metals is urine and the hepatobiliary fecal route. Now, sweat is a relatively minor route. That's not to say it's not important. I look at it as more preventive and prophylactic. Now, hair is an excretory route. By sheer mass, it's trivial compared to the other primary routes, but metals in hair provide a good cumulative time average record of exposure for many toxic elements. Now, the naysayers about hair analysis say, oh, it doesn't give you a precise indication of the dose or duration, and it may be contaminated by external contamination. Well, the dose and duration specifics are not the purpose. There's no claim for that. And also the external contamination issue is trivial when you consider the use of highly standardized wash procedures for the hair. Now, let's talk a little bit more about the fecal metals, because hepatobiliary fecal excretion is a significant pathway. However, fecal metals really only indicates very recent dietary exposure. That is because the dietary contamination of our foods, or the contamination of our foods, far exceeds the endogenous excretion through our natural processes. That is, there's just a biliary trickle compared to what's in our food today. So what we're looking at with fecal metals is primarily unabsorbed metals, and there is very high day-to-day variability. Just depends on what one eats. There is an exception for mercury in stool from the source being amalgams. Now, years ago, Dr. Bass and myself did a survey. We were doing fecal metals, and we put out a questionnaire and asked patients how many amalgam surfaces and about their fish consumption. Then we correlated those variables with the concentration of mercury in feces. And here you can see the plot of the fecal mercury concentration against the number of amalgam surfaces. And there's a nice linear, if not curvilinear, relationship between the number of amalgams and increased levels of fecal mercury. Now, we took a subgroup, and these were about 100 per group, of people that did not have any amalgams and asked about fish consumption. And lo and behold, not unexpected, what we found was that the high-end fish consumers had fecal mercury levels that were equivalent to people who had just 1 to 3 amalgams and didn't consume fish. So really not that much methylmercury in the stool, because methylmercury is absorbed so efficiently at about 95%. Okay, so that's the story about fecal mercury. Now, we do offer fecal toxic element testing, and we do express the metals as milligram per kilogram dry weight. And you can see here that this particular patient had a recent gadolinium enhanced MRI, many large amalgams, and was in fact a superfood juicer. And we'll talk a lot more about that. So there are people that use this test to show people, convince people that maybe what they're eating is not so good, but it's not such a good indication of the exposure that one's actually getting into the body. Now, let's talk about specifically why we're here. Urine toxic elements provides a convenient assessment of recent and ongoing exposures to metals and retention of cadmium and thallium. Two exceptions, not just exposure. And we highly recommend using a first morning void collection, or you can do a 24-hour collection. What we have found through our own research is that the true first morning urine void provides the same clinical information as the inconvenient 24-hour collection. Now, it's important that one only use the provided collection containers that we send out, because we've gone to great lengths to ensure that they're trace element free. Do not rinse the containers with tap water, okay? Not all tap water is so good. And do not collect urine from a diaper. I had a case one time of an incredibly contaminated, all natural, organic cotton diaper. It was absolutely astonishing. So please don't collect through diapers for very young or seniors. And very importantly, patients should avoid shellfish and sea vegetables for 1 week prior to collection. Now, I've seen this many, many times over the last 26 years. What a doc will call me and it's just freaking out because they found this exorbitant level of arsenic in the urine specimen, almost 2,000. If you really had a level of inorganic mercury that high in your body, you'd be in really bad shape. Okay. So what happens in this situation is this is actually organic forms of mercury that are arsenic that are very abundant in shellfish. And this particular case, the patient did confirm that the doctor confirmed that the patient did in fact have shrimp scampi the evening before. Okay. So importantly, when you see levels of arsenic this high, chances are it's from shellfish. Somebody didn't follow those instructions. These are arsenobutane, arsenylcholine, which are not metabolized or retained in the body. They're rapidly excreted in about 48 hours. So abstinence from shellfish and sea vegetables for a week prior to the urine collection. Very important to prevent alarmism. So here's our actual test report. Our reference values represent the 95th percentile from the NHANES-3 study, confirmed by our own population studies. We report the metals as micrograms per gram creatinine. That's an internal standard. And we are reporting 20 toxic elements. Now, do keep in mind that we do report the creatinine concentration. This is for a timed collection. And what we're looking at here is just simply a dilute urine specimen. This does not mean that there's any indication, there's no indication for compromised glomerular filtration. You can't just do that from a spot or a timed urine collection alone. Now, we do also offer 24-hour collections for maybe for those patients that you're not too fond of and you want them to drag that jug around or be sticking holes. It's just too cumbersome and it's not necessary. But when we do report as microgram per 24 hours, we also always give a backup report as the microgram per gram creatinine. That way, if there's a grossly misreported urine volume, money is not down the drain because we have the backup corrected for creatinine. Now, again, here you can see we report the 24-hour creatinine, and you know, again, you can't make any definitive conclusions about GFR from even just a 24-hour creatinine alone. You'd have to do a blood draw sometime in that period or during a time collection to actually calculate a GFR. So let me get to our case studies. This is the case of a trophy fisherman. This was a very athletic 35-year-old man. He had major vertigo, tinnitus, fatigue, and cognitive dysfunction, classic symptoms of overdoing it with methyl mercury. His first morning void, which represents the recent or ongoing exposure, his mercury was quite high at 3.7 compared to 0.8. He was eating a lot of the fish that he was catching. Now, the doc went ahead and did a provocation using DMSA because of his symptoms and the ongoing exposure. She wanted to get an estimate of his net retention. So she did a post DMSA. It was 1,500 milligrams DMSA as a single oral bolus dose with a 6-hour urine collection. And sure enough, the estimate for methyl or for mercury retention was about 100. So subtract the ongoing exposure, we're looking at about 96 microgram per gram creatinine as a baseline estimate of exposure. Now, I will say I knew this clinician very well. She did proceed with liposomal glutathione and about a 10 cycle course of oral DMSA. The patient, and of course, get the patient off these large game fish. And the patient said, came out of it saying he felt better than he ever had. Of course, we always feel better than we ever did right after we felt really bad. Okay, but worked in this case. Second case I want to show is very disturbing. A 7-year-old boy was playing with elemental mercury. He and his little buddies found a jar full of mercury in a local landfill, even had some in his pocket. And looking at his first morning urine void, his mercury level was 15. Again, should be less than 0.8. We knew what the source was, and it was a big problem. Now, for research purposes, I asked this doc to go ahead and collect the first morning void again for urine porphyrins. And as you can see here, the classic urine porphyrin profile associated with mercury lit up very, very well. So I like this porphyrin test matched with the exposure because it shows us a good indication of true physiological impact, okay? Disruption of a major physiological process, heme biosynthesis. Now, I want to switch and talk about cadmium because cadmium is a real bear. Cadmium is not only highly, highly persistent in the environment, but also very, very persistent once in the kidneys. There is very high soil to plant transfer of cadmium to certain plants, rice and tobacco being two examples, which is why we always see higher cadmium in past or current smokers. Shellfish are also hyperaccumulators, and depending on where the shellfish, oysters, clams are harvested, there may be more or less cadmium. Now, very important to understand about cadmium is about its absorption. Cadmium shares a divalent metal transporter with zinc, manganese, and iron, okay? And so in the body, when there's low iron status, there's an upregulation of the metal transporter, the ZIP8 in the gut. So the body's saying, I need more iron, increase that transporter to get more iron through the GI tract. However, when there's not iron there, it readily binds and increases the absorption of cadmium. So we just see across the board higher urine cadmium for women, particularly of childbearing years, and also for vegetarians. And again, relates to iron status. We'll talk more about that in a second. So as I said, the kidneys really concentrate cadmium, where it's associated with chronic kidney disease, hypertension, diabetes, peripheral and coronary arterial diseases, macular degeneration, and cancers, particularly testicular cancer. And there's an irrefutable association between urine and cadmium, kidney cadmium. That is, there's a relationship between urine cadmium and kidney cadmium. Urine cadmium is very consistent from day to day because there is a constant slow release of cadmium from the kidneys. And that's actually released in conjunction with the zinc binding protein, also very high affinity for cadmium, metallothionein. So we're seeing that constant destruction of the kidney cells with a slow, constant release of cadmium. So urinary cadmium provides assessment of long-term exposure and retention. So cadmium, high levels of cadmium, or just disconcerting levels of cadmium, what do we do next? This is a case of a 74-year-old male, very lean, hypertense, past 2-pack per day smoker. We can see that the first morning void cadmium level was 2.1, 95%. Percentile would be 0.9. So what do we do in this situation? We're very concerned about the kidneys. Check the 24-hour urine level of the protein alpha-1 microglobulin or beta-2 microglobulin. You have to use a 24-hour collection. You can't base it per creatinine because cadmium's effects on the kidneys. Number 2, improve iron status, as I just talked about, and increase zinc intake, very antagonistic for cadmium absorption. Also, because of its association with vascular disease and diabetes, I think it would be a good idea to check all cardiometabolic risk factors. We have a tested cardiometabolic profile where we're looking at serum level and address those risk factors. So did that for this particular patient, 74-year-old, very lean, hypertense, 2-pack per day smoker. Lo and behold, the insulin, fasted serum insulin was extremely low, only 1.5, glucose 126, and glycomark, the 1,5-anhydroglucatol, was very low. So that's an indication of postprandial hyperglycemic episodes where the very high levels of glucose prevent the resorption of the naturally occurring 1,5-anhydroglucatol, and so we see very low levels in the serum. So really not a good setup with respect to diabetes for this cadmium-laden patient. Looking at cardiovascular risk factors, the lipid profile was absolutely horrendous bad for this patient. But I just picked out a couple of my favorites: the plaque, the lipoprotein phospholipase A2 activity was significantly elevated, as was the hsCRP. That combination is like a double whammy. Also, look at the homocysteine, 18.7 for homocysteine. Lots of work to do for this patient. And lo and behold, the doctor had no clue, significant, at least initiation of kidney disease. The cystatin C, very high in the serum, not being cleared. The creatinine, very high, very poor creatinine clearance. The estimated GFR at only 36. Should be greater than 60, more commonly around 100. So lots of work to do with this past cigarette smoker. And the initial tip-off was the unprovoked urine cadmium level. Now, thallium is something that I see way too much these days. Thallium is also a bear. It's very rare in the Earth's crust. It's taken up extensively from contaminated soil by kale and other brassica family vegetables, as well as lettuces. Primary sources of thallium right now are frac waste brine, fly ash, cement dust, and also it's a byproduct of smelting for copper, zinc, and lead. Now, the traditional metal toxicologists have stated that thallium is more neurotoxic than mercury. It is a potassium antagonist. It's only a +1 charge. It goes where potassium goes. So it has a huge volume of distribution and physiological impact in the body. If anything that goes where potassium goes is going to affect a multitude of processes. The primary symptoms associated with excess thallium are fatigue, headaches, depression, sleeplessness, mental aberrations, psychoses, cardiac arrhythmias, endocrine disorders, polyneuropathy, and alopecia areata, hair coming out in the clumps, by the clumps. Now, the most severe cases that I've seen or been involved with involve the green juicers or the daily green smoothie people. And here's a case of an individual that was consuming a half of a bag of, quote, organic spinach per day. And you can see the thallium level was 2.2, a level of consideration, not 0.4. Now, we did in fact confirm, we directly analyzed the spinach that this patient was consuming and confirmed the very high thallium content. So be warned, just because it says organic on the package doesn't mean tell you anything about the soil in which it was raised. Okay. Now, the very worst case of thallium, I'd say toxicity that I've ever saw was a 48-year-old female presented with major fatigue, cognitive dysfunction, polyneuropathy, also hallucinations, and alopecia. She was a daily kale smoothie person under the direction of her unknowing or underinformed clinician who was beside herself when she found out what was going on here. So here we have a level of urine thallium. The 24-hour value was 8.8, should be less than 0.5. And since the 24-hour collection was reported accurately, both the 24-hour and the microgram per gram creatinine were very, very similar. So beware of thallium. Elevated thallium will show up for 60, maybe 30 to 60 days after a single exposure, which is rare. And the hair loss typically occurs about 3 weeks after a primary exposure. So to wrap things up, my takeaways are really quite simple. Exposure to toxic metals can contribute to the total toxic load and oxidative stress, and may impede endogenous detoxification of chemical toxicants. Urine metals testing provides an assessment of recent and ongoing exposure to 19 toxic elements and longer-term retention of renal cadmium. Very, very nephrotoxic. A true first morning urine void provides the same clinical information as a cumbersome 24-hour collection, and I stress true first morning void. And finally, with an abnormal urine metals in the test results, ameliorate the exposures. Number one, mind the exposures, and then consider your efforts of choice to perhaps enhance metal decorporation. Okay. So I thank you ever so kindly for your attention. For further information, you can contact us by phone or by email. And again, I look forward to your questions and thank you kindly.